The fact that the human body is so complex that there is no right answer, right? It's a constantly evolving thing. If you look at like an engineering or a circuit or a mechanical problem, there's a solution that you can solve for, right? And that was literally the end of my medical training career. And so I ended up going into engineering for doing systems processing, AI machine learning before it was a buzzword. Anybody that says they can do AI for personalized recommendations today is either lying or naive. It's not possible. The data does not exist. And ultimately, what I think people have kind of figured out is the only person that has a vested interest in me getting healthy is me. Because synthesizing 10,000 patients across 10,000 labs and 10,000 markers is not feasible, but it is with technology.
Welcome to the Health Signal Podcast, where we make health data make sense. I'm your host, Boris Berjan, and on this show, we connect with trusted health experts who help us decode the trends, science, and signals shaping our health. Whether you're optimizing for longevity, managing stress, tracking sleep, or just trying to make smarter decisions in a noisy wellness world, this podcast is your accessible expert. Let's get into it.
Jeremy, welcome to the pod.
Awesome. Thanks for having me. Appreciate it.
Pleasure to have you, man. So, obviously, you've had a decorated career in health and medicine in many different formats, and you've ended up in a very, very specific industry. So, I'd love to learn, when you were starting out, what drew you to medicine and med tech, and how did you end up there?
Yeah, so I've always been interested in health. So even as a kid, I was always focused. I think I remember I got like the complete book of abs, the zone diet, eat to win, or something along those lines. So I've always been interested in health and biology. I think part of it is my engineering side, but also the fact that the human body is so complex that there is no right answer, right? It's a constantly evolving thing. If you look at like an engineering or a circuit or a mechanical problem, there's a solution that you can solve for, right? I was sports medicine first, and then I realized I didn't want to be an athletic trainer on the sideline of a JV soccer game for the rest of my life. And so I was like halfway to my certification, and I switched to biomedical engineering. And then when I got to biomedical engineering, I wanted to do an MD PhD. So I wanted to be an MD, and then I also wanted to be PhD, so like a research physician type of thing. Unfortunately, at the time, nobody actually told me. So being biomedical engineering and getting MD PhD, it means NIH money. And so when you go apply to a program, molecular biology and biochemistry controls the NIH dollars. So when they see an applicant come in that's going to say, hey, you're going to do your PhD in engineering, that takes money away from them. And it wasn't until I was in my interview process at Vanderbilt University, I can't remember who the professor was. He's like, dude, we love you. You're never going to get accepted because that'll take dollars away from that department. So I got into medical school, but I did not get accepted to MD PhD. And then funny story, I was with my buddy in San Francisco. I was about ready to graduate, and I was considering going to medical school. We went out, ripped it up one night, tripped, hit my head on the back of a taxi cab, and split my eye open. So that's actually the scar over here. And we didn't know where to go in the morning. And I remember he was living with three buddies in San Francisco, and they had one roll of toilet paper. And I used the whole roll of toilet paper soaking up the blood, which is just a funny story, but ended up at Stanford University Medical Center. And the resident there, he was like, he's going to stitch me up. He's a plastic surgery resident. He goes, don't do it. And I was like, really? I was like, it's kind of weird. Yeah. He goes, I'm a plastic surgery resident, Stanford Medical, right? What do you think I got on my boards and my MCATs? And I was like, I don't know, top one. He's like, I was top performer. He goes, I applied to law school midway through medical school. He goes, I can't afford the closet that I live in right now, and I'm at the best training academic institution. He goes, don't do it. And that was literally the end of my medical training career. And so I ended up going into engineering for doing systems processing, AI machine learning before it was a buzzword. Yeah. And so that was what brought me into like the tradition, because I could impact more people. I was doing research studies. I was actually delivering technology. And then I realized, look, I don't want to be an engineer. That my engineering lead was like, hey, you need to get your master's or PhD. Didn't want to do that. Yeah. So I ended up product marketing, got into technology. really around software, which was my background and kind of my expertise. And then, we acquired a bunch of EMR systems. My wife's a practitioner, had my own health journey. And I was like, this is the future of health. And I wanted to build technology for it because I saw people using software that wasn't designed for it. And that's really where my journey came into building technology for this kind of personalized health intelligence types of practitioners.
It's a cool story. I
Yeah.
think I want to touch on the moment that the surgeon told you, "Hey, I'm
Yeah.
the top guy.
Yeah.
Don't do this." Do you feel like that jades doctors maybe? Like, I love your opinion on they do all this work for, I think it's 10 to 12 years all in, when you include residency plus school plus bachelor's, etc. And then you're like 300K, 400K in debt, right? But wouldn't a plastic surgeon start making like 300K a year at that point, essentially?
Yeah, I mean, I think the
Or
challenge
are the
is,
metrics a little bit different than that?
I mean, look, you're digging yourself a hole, and plastic surgery, you can get out of that hole.
Yeah.
But why can a plastic surgeon get out of that hole? They're cash pay, right?
Yeah.
People are paying out of pocket, so they're able to actually do the things that they want to do.
Right.
When you think about a traditional GP, they get into it because they're empathetic, right? They want to help people.
Yeah.
They want to practice medicine, and they can't do that in the system today. And that's really where the burnout comes in, right? And so, the path I was going on was not plastic surgery. I was not fascinated by that. I'm thinking about systems biology, physiology, chronic disease.
Yeah.
You can't do that in the system today because you just burn out and you can't make any money and you never get out of the hole.
Yeah. No, that makes sense. I've known some doctors and like they do all of that, then start making money, but then they're terrible at it.
Yeah.
So they bought like 2 cars right away their first year. It's like it becomes this like hamster wheel of doom, right? I think the statistic is, and maybe even better than me, like doctors are the worst financially savvy people on earth. Like they just don't have a concept of how to manage, because they don't have any money. Then all of a sudden they do. And they have these crazy work schedules.
Yeah.
And so they're like, well, any time I have off, I'm just going to spend all this money. But then, so this is this vicious cycle.
Yeah.
It feels like.
Yeah, and that's definitely the case. So with the burnout, clinicians are wanting to get into the cash pay, concierge, whatever you want to call it, world. And they definitely come out and they're like, well, now I want to actually do medicine. I actually want to work with people at an individualized level.
Yeah.
But they have no concept of how do I get a client? What's my pricing strategy? What's that? Because when you graduate med school, you get an insurance contract, people show up on your door. Now all of a sudden you want to shift your model. How do I actually, I don't have that lever anymore. I need to attract people. How do I talk to them? How do I create demand for my services? Yeah.
Let's talk about that. I think so. Doctors graduate, get into medicine, realize some of them, there's no real path to growth here, or I'm limited in what I can do. And so you're basically saying they're deciding to go cash pay versus insurance, which is most of the US healthcare system. Talk to me a little bit about what do those transitions look like, why that's becoming more popular now, and what kind of sparked it?
Yeah, I mean, I think the biggest thing right now is, one, the financial model is set up that you have to do a volume-based business, right? And somebody wants to do care. Care is not volume. Care is individualized, right?
Yeah.
And so that's the motivation to get out of it, right? Because they came into it thinking it was going to be one thing, and that's not the way it is in the world today. The hard part about the transition is how do you plan for that, right? So what we see with a lot of practitioners coming out of traditional insurance-based care is what's the planning process. So what they typically will do is, instead of 7 days a week, but they cut down to 3 days a week, right? So I worked with one clinician. She was at the VA, great job, terrible work environment, but it was stable, right? So she went from 5 days a week to 3. And then in the 2 off days, she started building her personal business. Right. And so that becomes the transition process, because the demand's there. So they can just say, well, I'm only going to work 3 days a week.
Yeah.
And so now they're able to have this steady income while they build that business on the side. And at some point they can flip over. Right. And that's really the transition process. And I think Laura Frontero, who's been very transparent about that, nurse practitioner at Kaiser, and that's exactly what she did.
Yeah.
She planned, but build her audience. And then at one point she said, I'm retired from Kaiser. And that at that moment, she knew she had the demand on the one side to cut it off and then fully commit. And the hard part about not committing on one side is you kind of never commit to doing the business.
Right.
But once somebody truly believes that that's where they want to be, then they have that plan and they're like, okay, this is my cutoff date and that's my target and that's the successful transition.
Gotcha. I feel like maybe like 100 maybe let's say even 50 years ago, and I think the stat when I looked at it was there was a lot more individual clinics. Like you had a family doctor in a town, you had clients in that town. I think it was less and less people over the years were starting their own clinics, being like a general practitioner for X amount of patients, and then joining these bigger conglomerate hospital chains because it like liability, risk, all these things just made more sense to them. Do you have an opinion or a thought process on why that started to change and how?
Well, it's liability and insurance, right? So it's economies of scale. So, you think back to when I was a kid in the 80s or even the 70s, your pediatrician was an independent practitioner.
Yeah.
They ran a clinic. I remember him, Dr. Strimling. It was his own clinic. And then Strimling got acquired by a medical group, right? So it was a group of pediatricians that came together to be, Eugene's family pediatrician clinic. And then what you can do is now you can move your patient demand around those. And then the hospital system, Sacred Heart, I think at the time, which is now Peace Health, acquired them, right? So it's like, well, we have a hospital and now we want to own primary care and we bring that together. And now we're simplifying all the economies of scale. So billing goes through a central person. You don't have to have a billing person sitting at the front desk with your front office. Billing is a separate building. And so as pricing pressures came in or reimbursements came down, you had to build that economy of scale. And so you can't come out and be an independent practitioner anymore because you have to have all those things, right? Just think about that one head count is a full-time employee. And if you think about your margins and reimbursements coming down, you just can't make it work unless you're a part of a system. And that's really where the incentives kind of drove this kind of vertical integration approach.
Yeah. Which makes sense, like that makes sense in terms of like systems thinking.
Yeah.
But then do you feel like that's severely diminished the patient experience, the patient affinity to that provider, the amount of time they can get with them? And then what do you feel like the impact's been on the general populace because of it?
Yeah, I mean, I have a great story. So my dad was on the news, right? So my dad, Medicare, he had his local, in that same medical system, and it got vertically integrated. I think it was, it might have been Cigna or Humana came in and acquired Oregon Medical Group, OMG.
Yeah.
And they basically, when they came in and they bought out the health system, all of the physicians quit. And so then my dad got a letter saying, hey, by the way, you have no primary care anymore. So here's a virtual option and we'll try to find you somebody, right? And that's really where this challenge comes in, is because it's so bottom line focused that personal relationship that you had with your trusted authority goes away, because I may see you today, I may see him the next day, I may see that person the next day, and nobody actually knows me through my own individual health journey.
Yeah.
And health is not like buying a phone, right? It's you have questions, you have concerns. What if, what about, I'm feeling like this, my side effects are this, and they don't know you. And that really is what really has basically made people give up on the traditional healthcare model.
It's true, because I have like a traditional medical doctor that is assigned to me. When I go to book appointments, they're like, she's not in that day, so we'll give you this other doctor. I'm like, I don't really want to see another doctor, and then when I go see them, I feel like the conversation is them reading off the CDC guidelines. They're like, well, they recommend this, they recommend that, etc. I'm like, there's no point to you in this room. That's how I felt. I'm not saying there's no point to being a doctor, but there's no point to you if you're just going to read. I actually had this conversation. I'm like, I don't really care what the guidelines are saying. I'd like for you to listen to me and have input on what I want, right?
Yeah.
And I don't think there's anything more disrespectful when people feel like someone's just talking at you
Yeah.
And they're just saying general things that
Yeah.
you can read off a teleprompter like that.
Yeah.
Why would I want to listen to you, right?
Yeah, exactly.
Maybe that's a good segue into nowadays people are spending more out of pocket. There's this, I would say it's a growing market. I wouldn't say it's by any means the biggest part of the marketplace. It's still insurance-based traditional model. But what's your thought on why has longevity, concierge, even functional medicine, things like that have started to take some legs that aren't insignificant anymore?
Yeah, I mean, regardless of how you felt about the pandemic created exposure for people understanding how the incentives are. Then you factor in terms of what pharma is wanting to do in terms of CDC and recommendations and how those things were, it was trusted at first and now it's mistrusted. Most of the majority kind of mistrusted what that guidance was looking back at that. So that's one incentive on the consumer side. The other side is the shift in the out-of-pocket responsibility, right? So before it was always a copay. Then it was a copay that got higher and higher, and then we went to high deductible, right? And so now people are paying out of pocket up front before they hit their deductible, right?
Yeah.
And so and they're like, well, wait, I'm paying for something that's not actually fixing the issue. And then now you factor in what I call the Joe Rogan effect, right? It doesn't matter who's on the podcast with Joe Rogan. They're always talking about blood work. Oh, I went to Ways to Well. Oh, what does your hormones look like? Your diet, da 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 da. And now it's in the conversation. People are talking about it, right? Everybody, I kind of live in my own bubble, but everybody is asking me, well, should I eat this? Should I not do that? What supplements should I take? What about this? What about that? And that is what's driving the consumer accountability. And ultimately, what I think people have kind of figured out is the only person that has a vested interest in me getting healthy is me, right? And I think 20 years ago, it was like the only person that could help me get healthy was my physician. But as we just talked about, I don't know who that physician is anymore. They don't know me. They don't know anything about me. So if I care about the most important thing to me, which is my health, I have to take ownership of it. And I think that's the big shift.
You actually brought up a really good point. I'm going to absolutely butcher this number, but I was reading stats and I think we'll put it in the notes, whatever number, but it was like
Right.
36% of Americans don't have a general practitioner anymore, or it's going towards that. Essentially, there's a large amount of populace that now doesn't have a doctor. Everybody grew up with Dr. So is my family physician. That's who we go to. So I think that's a good point, is the trusted authority actually feels like has gone away a lot because A, you don't see them ever, and B, you can't trust them if you don't see them.
Yeah.
So the Joe Rogan effect is interesting, and I think obviously has a large reach. Do you feel like innovation has also allowed us to get to this point, and if so, in what way?
Yeah, I mean, obviously there is a lot more ways to quantify yourself, right? So I have an Aura on the Apple Watch to sleep apnea testing now. That is creating insights at the individual level, right? So that's really where kind of the biosensor data giving me feedback, right? So I know that white corn doesn't work for me, but other things do, right? And I think that is what's kind of giving people the tools rather than just having your annual blood work once a year, which was 5 years ago. Now people are looking deeper, right? And so they're constantly like, well, I have an Apple Watch and it told me I didn't sleep well. What does that mean, right? What can I do to improve my sleep because my wearable prompted me to, right? And now I'm like, oh, now I'm listening to Andrew Huberman or Peter Attia or you name it, right? And so that is what's kind of creating this gearing effect of getting people more tied into what their physiology is and what works and what doesn't work for them.
Yeah, no, it's a great point, right? And I think biohacking, for better or worse naming of what it is,
Yeah.
has become popular, and I think some people are definitely over it and some people are way more into it. What's your thought on biohacking?
Yeah, I mean, I think it's a bad word. I think originally doing a thing like a continuous glucose monitor and all that was considered, quote, biohacking. It might have been Ben Greenfield. I don't know if you asked him the same question. biohacking in my mind is like literally, hey, we're gonna go take what works for a dog eye and put it into your eye so that you can see like a dog, right?
Yeah.
Biohacking is not hacking. What we're really talking about is optimization or health understanding. And hack, I think, is just gives it a hacky type of feel to it. I think really what people are doing is I want to understand my body. I want to feel better. I don't want to have night sweats. I want to sleep better. I want to be, as present and as connected to what I do every day that makes me passionate about life.
Yeah.
And so it's almost like we just need to take that term and shift it into a different term, right?
Yeah.
And then the other side of this is like quote unquote longevity medicine.
Yeah.
Well, okay, we're in year 1 of longevity medicine. We have no outcomes until we know somebody doesn't die, right? So is it really longevity? But again, it all comes back to this idea of how do I optimize so I feel the best most for whatever that means for me. And I think that is, whether you call it longevity, whether you call it biohacking, it's the same thing. Right?
Yeah. I think you nailed it with like the wording matters, or the definition of what we're talking about matters, because I've had this conversation with multiple people now.
Right.
As somebody who's building health technology that will hopefully extend life, or at the very least make it better today, everyone talks about we're building longevity or longevity protocols. Well, what does that mean? Because if the life expectancy is still, let's just call it 82 or whatever it is, and we can get rid of the big four, cancer, diabetes, cardiovascular, etc., we only gain 4 years of life. So sure, you could argue quality of life is not as good the last 20 years, and that can be improved. But until we have actual breakthroughs like CRISPR or nano particles optimizing your cells, I haven't seen it, right? Like no one's lived to 140 and said, these were the things that led me to that. Where are you at with all of that stuff, extending life, etc.? Have you, because you're a technology company, have you seen things that are exciting for you? Do you share the same sentiment that I am, etc.?
Yeah, I mean, so like I said, I am an AI ML engineer before it was cool, right? But artificial intelligence, machine learning has been around forever. The challenge with the human body, which goes back to my original story, which is why I'm so fascinated as an engineer, is there are so many combinations and permutations and inputs and outputs that there isn't a way to simplify it down to a specific this for that, right? And so when you think about things like the ladder of causality from Judeo-Pearl's The Book of Why, you have correlation, causation, and imagination, right?
Yeah.
And for the human body, it takes imagination to try to synthesize what are the biggest levers that you can pull on, right? If you think about, and this is a terrible analogy that I've never used before, but I'm going to break it out. If you think of a cargo net, right? But it's made up of a whole bunch of different types of string.
Yeah.
Right. You have rope, you have fishing line, everything, and you're trying to move the bowling ball around in that cargo net. It may not make sense to pull on the fishing line. It still matters, but it may not have a material effect. But what is the biggest, thickest rope that you actually lift and it moves it in the direction that you want to go? We don't really understand that because we don't even know what the rope sizes are, right? How do we actually pull on the levers? Because we haven't really taken a consistent understanding of how to capture that data, what we need to quantify in order to measure its impact, right? And so when we, I call it step 1 of a marathon, right? We're very early stages. The technology exists. We just haven't put it into a way that we can truly understand to say, for you, this is the big lever and this is the small switch. What are those things? We don't know yet, but that's where we need to go. And I think that's where this industry really transforms. Is it tomorrow? Absolutely not. Is it 18 months? I don't know. Is it 5 years? Absolutely. Where it is in between, I have no idea.
And how would we go about getting to that point? Is it always on biodata? Is it biodata plus blood work? Is it different ways of measuring the body to understand what those strings actually are? Like how would we get there, and what are you seeing in the market?
So yes.
All of that.
Yes,
okay.
It's all of that.
Yeah.
And that's the thing is when you have the combinations and permutations of all these different things, we have to understand the system as a whole
Yeah.
to be able to understand what is or is not important. absolutely biosensor data is important, right? That's the glue. That's the glue between the blood work. But, we can't do blood work every single day consistently all the time, right?
Right.
So we have to find proxies. So can we take a periodic set of data, like a blood panel, run a CGM for 2 months, measure what's happening, the dietary changes, the sleep impacts, the exercise impacts, run a blood panel the next day and say, okay, we've got this as the input, we have the biosensor data as another input, and then can we reasonably predict based upon what the results that we saw in our study, based upon what was the outcome, right?
Yeah.
And is it RDW basophils or is it HbA1c? We don't know because we don't have that data in a way that's powered in the way to be able to uncover that. But the only way that we get to the power to be able to answer that question is by getting it on every single person
Yeah.
and getting consistency around that, right?
Right.
And we're starting, it's been a bit of a kind of shotgun approach and people are all over the place. But now you're starting to see these different consumer models pop up and they're consistently using a lot of the same stuff.
Yeah.
They're layering in the biosensor data, they're layering in activity tracking, they're layering in sleep tracking. Now we're going to power that data set that we can actually do a 70-30 split to say, okay, what is the question that we think we want to predict the answer to? And let's see if we can predict it, create a model. And then in that 30%, okay, let's prove that we didn't over train it on its own data and see if it's actually predictive at scale. And that's how this is going to start to evolve.
Gotcha. Let's get a little bit into the path that you took. I think it was different than where you started in terms of education and scope of where you want to be in the field of medicine. You basically have a health intelligence platform. How did you, A, get to the point where you wanted to build that? B, what prompted it?
Yeah. So, I was in data processing as an engineer, got into the electronic medical record world. Then when I had my health transformation, I was at the same time, I was acquiring other EMR businesses. And so one of the things that I saw was that, look, the electronic medical record has to be built for the delivery model. So although it's an umbrella of technology, you can't take a hospital EMR and put it into skilled nursing. You can't take skilled nursing and put it into podiatry. Everything has to be built around that.
Yeah.
And then going through the process, I had a spreadsheet, I had a Dropbox folder, I had PDF documents and everything else. And if you put that in kind of the traditional model, it's might as well be a glorified Dropbox, right? It's just lab results, it's your notes, it's your tracking, whatever. And so what we wanted to do was build the platform in a way that was actually built for me as a patient to figure out and be able to track my own health, but then also help clinicians be able to do it faster and more effectively. So my journey really came from an engineer to product marketing to SaaS acquisitions, corporate development strategy investment, back to engineering. And the funny thing was, as I always joke about this, is when I started as a AI engineer, I had to write all the algorithms. And I stopped doing tech because I was doing marketing and acquisitions. And then I show up back in the market 20 years later as a tech guy.
Yeah.
And I'm like, this is fucking cheating.
Yeah.
I was like, wait, I can just give a data set to AWS SageMaker and it's gonna run a bunch of models and spit it out. I'm like, I literally would spend days coding a neural network in MATLAB or LabVIEW, and now you can just do it for free, basically. And so that was really my tech journey, and I was like, now I think the tools are in place to really make this scalable, and also the compute power. It's a lower cost. You don't have to have that engineering and the coding effort. You can use the off-the-shelf tools to really kind of say, okay, let's synthesize some of this and let's find where those high points are. And then we can dig into the high point with a more detailed deep dive.
Last set of topics, the audience you cater to is more on the functional medicine, integrated medicine, whatever words you want to use. Like, again, definitions matter, integrated, all these words. And the whole premise of that industry is we look at things completely different than MDs. Why did you decide to A, cater to them? B, what do you see in terms of upside in that industry? And then C, why should consumers care about seeking solutions outside of traditional?
So one, the broad-based data is where I was as an engineer. That was what attracted me to the industry. It's, hey, we're looking beyond just your traditional blood work, right?
Yeah.
Or we're looking beyond what is the standard. And when we say standard of care, it's not to be disparaging. There's literally like, if it's an empirical set, a rule set. If HbA1c is above here, we do this, and you recommend this, and this is the process, and it's literally a structured rule set. Functional and integrative does a more broad-based approach, and then they try to take in consideration of everything else, which is much more of a systems understanding, and it's much more nuanced. And that's just personally my background, what I love and what I'm attracted to. But we're also in the world of this industry is also splitting, because it's even going back to the empirical rule set.
Yeah.
If your total tox or your food sensitivity or your metabolomics is this, then you supplement with this.
Oh.
But it's interesting to see how, I think it's more of a human protective mechanism, right? We're always, as a survival instinct, we're trying to synthesize and create rules like, hey, I've never seen a lion before. That lion ate the other person. Now I avoid lions, right? So it's, as we learn and grow, we simplify it.
Yeah.
In functional medicine, it's kind of falling into that empirical if-then statements. And now I think where the exciting part is more around this kind of idea around bioregulatory. Thinking about the energetics. So now it sounds woo-woo and crystals and heavy breathing, but the reality is, and Joe Dispenza talks about the quantum, enter the quantum effect. But the reality is, look, everything is energy. So what does that actually mean, right? The representation of, your energetics. So when we talk about sympathetic, parasympathetic stress, that is real, right? That is a physiological mechanism. That is your negative energy response to a stressful action. And when you're in sympathetic or parasympathetic or sympathetic state, how does that actually impact? Because that is what's driving what those biomarkers are, right? So now we're thinking fully along that line. And then we talk about sleep, mindfulness, stress management, understanding those things and recognizing them and calling them out and becoming part of the health program, not just the objective data. And so it's all the things, right? And so we do, like I was saying, the functional medicine's trying to become reductionist about it.
Yeah.
But it can't be that. We're too complex. There's too many combinations. There's too many permutations. And so people are now like, oh, okay, when we look at the whole situation, heart rate variability, can we do autonomic stress, POTS, all this stuff? It is truly complex that we can't simplify it into empirical rules.
Gotcha.
Yeah.
Do you feel like the simplified version of a protocol or advice to the client will notoriously become AI analyzes all of those things that are complex, and then we can actually say, like, do this, and it's the accurate answer?
Yeah, so I say this a lot. Anybody that says they can do AI for personalized recommendations today is either lying or naive. It's not possible. The data does not exist. Where I think this comes in is we go back to that idea of the ladders of causality. So correlation, causation, and then imagination, right? AI can get us to causation. It can truly say, hey, look, you had IBD, IBS, you had dysbiosis, you had a low akromansia and all that stuff. AI can surface that to an individual. The imagination component, even in the language models, we don't have the imagination concept. You don't have in a large language model writing a movie script that's never been seen before, right? Yeah. It can mimic what's been done in the past, but it can't think forward. So where this idea of imagination is, this is going to empower a clinician because AI is going to surface the insights to say, okay, here are the high points within the system that we see as opportunities. And then I, as a clinician, need to look at you as an individual and be like, are you willing to go gluten-free? Are you willing to pay for certain things? Are you willing to reprioritize your sleep schedule? That imagination is where it meets the individual where they're at to determine what is the course of pathway. Yes, AI can surface all of the data from history to tell you where to go, but you never really know where that person is willing to do until you actually meet and connect with them. Then maybe we start small. Maybe, hey, look, let's just talk about your glucose response and put you on a biosensor and start making the dietary choices just to get a win on the board. And that win on the board becomes the motivation that gets you to step 2. And to step 3 is the next step, and step 4 beyond that. But we can't just start at step 18 if that person doesn't see a win on step 1.
Yeah, makes sense. Makes sense. So let's dive into what you're working on. You built a intelligence platform that contextualizes a lot of this data. Can you tell us, A, where you're at today, and then B, where you see the future of health technology?
Yeah. So we built a platform to streamline the workflows and the scalability. So doing individualized health programs is not scalable today, right? Because you're different and you're different and you're different.
Yeah.
So how do we actually create a workflow process that creates efficiency? So that's really what we are, is we're an efficiency play. Then we want to get to being able to get to that next layer. So thinking about correlation, causation, and imagination, start to surface those correlations. Again, driving efficiency. So yes, now you're super efficient and your client onboarding and your pass-through and everything else. Then you next go to, okay, instead of having to go to PubMed and figure out what this helminth parasite actually means, it just tells you right at the point of care. So again, saving 5 minutes, saving 10 minutes, saving 20 minutes. And then as that flywheel effect starts to improve and drive better outcomes and drive better data and drip better efficiency, then we can start to really tease out. And that's really where the future of this goes, is teasing out those systems insights that a human wouldn't necessarily have recognized, because synthesizing 10,000 patients across 10,000 labs and 10,000 markers is not feasible, but it is with technology.
Yeah, makes sense.
Yeah.
Last question before we wrap up. What are you the most excited about in terms of health tech, technology, where we're going? Can we live forever? Anything along the open-ended question. I want to know from you, as who's somebody who's engineering in this field and building the technology to get us to those points. Maybe one thing or a couple of things that you're personally excited about and are looking forward to.
Yeah. So when I started this journey pre-pandemic, I would get on calls with venture capitalists and they'd be like, well, when are you going to go sell to a health system? And I'd be like, we're not. And they'd be like, okay, meeting over. Then the pandemic hit, right? And this is where the transition was. And then I had those conversations and I was like, look, the pandemic hit, people now recognize poor metabolic health is leading to negative outcomes relative to all of that stuff, all of the stuff that happened with long COVID and deaths in hospitals, obesity, everything else. My biggest concern was, I'm worried that post-pandemic, we fall back to pre-pandemic behaviors. Applebee's, $2.99, blah, blah, crappy eating. We got through the pandemic and we just go back to our old ways. What excites me is we didn't. And consumers are now more aware about their need to take over their own health. I was worried that we would fall back to being lazy, and it's only accelerated. Again, going back to the Joe Rogan effect, right? We had one of our practitioners went on Joe Rogan, talked about the importance of genetics and methylation, absolutely crushed it coming out of that. That's how hungry people are for getting that additional information. And when we think about healthcare and value-based care and disruption never comes from within, right? Uber didn't come from the taxi cab industry. Airbnb didn't come from the hotel industry. What they came from was the consumer need to solve a problem that they weren't aware of, that they are now acutely aware of, right? I don't know if you remember this. I remember calling taxis on a Friday night in PB to go out. Somebody always stole my taxi, right? It was a problem that existed that nobody ever put its finger on. Yeah. To demand, and the consumer demand completely changed that market once we knew that problem existed because of companies like an Uber or an Airbnb. Now people understand exactly, like, healthcare has a major problem. It's not helping me. So now I, as a consumer, and I, as a society, am going to completely do it myself. And I think that's the most exciting thing. People, I'm going to go to the health conference next week. People still there think that value-based care and digital health and and everybody there is unhealthy, unhappy, and unsatisfied with the healthcare system that they live and breathe in.
Yeah.
And they all want to be where we're at today. And so, it's like I said, step one of a marathon, but you can just see this is where the groundswell goes. And the great thing is that this market is a complete blue ocean. There's plenty of room for, we don't have to think about competitive differentiation. All we think about is market development. And the most important thing that was really great about our industry is the incentives are aligned. People get healthier and happier. Our practitioners make more money, and then we do well as a business. Every single incentive is aligned, and you can feel good about what you do during the day versus saying, hey, I'm going to go re-import Alibaba stuff and rebrand it and sell it for a markup, right? In our industry, we're truly driving better outcomes, and it's good for the world. It's good for people. It's good for our friends, good for our family, and just good for us as career entrepreneurs. So it's a great place to be.
Amazing.
Yeah.
Thank you, Jeremy. Where can
Awesome.
people find you, connect with you, your company, and if they're a provider or practitioner, how can they find out about your company?
Yep. So we're Biocanic, biocanic.com. Our hashtags is @Biocanic everywhere you go. Just go to the website. All the information's updated. We're always working with practitioners. And then we also have our own community called the Health Intelligence Exchange. You don't have to use our product. It's all about creating the collective knowledge, empowering practitioners to be more successful through sharing information, creating best practices, learning for business approaches. And so that is hix.biocanic.com. Like I said, anybody can join that, and it's really our gift to the community to empower practitioners to be successful.
Amazing. Thanks so much. You were awesome.
That's it for this episode of The Health Signal. We hope you're leaving with one small insight you can use and one big idea to explore. If you enjoyed this conversation, be sure to follow the Health Signal podcast and leave us a review if it helped simplify something complex. To learn more about how Thea is helping providers and patients make data-driven health decisions, visit theahealth.ai or check out the links in the show notes. Thanks for listening, and we'll catch you next time.